and function with only the bad eye. But as long as they have useful vision in that eye, most of the time the family is not going to let you take that out and see whether the children can.
Dr. Batu, you want to comment?
Yeah, Professor, it was a very excellent lecture. Just I have I just want to correct me. Like you mentioned about the sporadic cases compared to the NF1 related cases are more aggressive tumors. Like is that so?
The sporadic cases are more aggressive.
Yeah. So in a case of a suprachiasmatic lesion, the chiasmatic lesion, what are your indication for a either biopsy or a surgical excision, and what is the extent of your surgical excision?
Right. So typically, if we can't tell for sure by imaging whether it's an optic pathway glioma, then that would be an indication to do surgery to get a diagnosis. Typically, if we're going to start treatment, we feel like treatment is necessary, then we would like to get a biopsy first so that we can get molecular profiling on the tumor before any treatment has had a chance to alter the molecular profile of the tumor. And then if children are having trouble with problems from mass effect, so for example, a child who presents with hydrocephalus, if we can safely debulk the tumor and avoid having to shunt the child, then we would prefer to do that. So those are the main indications.
Yeah. Another thing you mentioned about most of these lesions are a pilocytic astrocytoma.
Correct.
Yeah. They are very discrete lesions, but in some cases we can see like we also often see like they are a diffuse infiltrative lesion or sometimes pilomyxoid. So your management strategy changes with that?
That's an excellent question. Peter Berger has described the pilomyxoid tumors in younger children. And we've all had cases now where we operated on children when they were young and the pathology was read as pilomyxoid. And then when the tumor recurs a few years later and we reoperate, it's now a pilocytic. And so now there's called into question whether pilomyxoid is actually just a stage in the maturation of a pilocytic astrocytoma rather than a distinct entity. We do know that when we see those pilomyxoid features in the tumor, that it's more likely to progress and act ugly. But there's some discussion in the literature nowadays that that may just be a maturational stage in a pilocytic astrocytoma.
Okay. Thank you, Professor.
So, I just get a little bit clarification. So, in sporadic optic pathway glioma, now if the patient has a tumor limited to the optic nerve and the vision is very significantly compromised, you advocate early surgery, all right?
That's correct.
Okay, and a tumor which is sporadic and involving is non-neurofibromatosis and chiasmatic or suprachiasmatic, you would do a biopsy for the molecular typing and then go on for the type of treatment depend on the age, if the patient doesn't have a big mass. Is that right?
That's right.
Okay, and so in a neurofibromatosis cases, we are much more, we hold back everything unless the patient is suffering from that.
That's right.
Summarize. Okay, so I have some questions from the audience. So I'll just take it for you. This is from Dr. Hitesh. During surgery, how do you know that you have removed enough?
have improved imaging that can actually demonstrate for us where those normal or working visual fibers are within the tumor, I'm comfortable debulking what's gelatinous and obviously tumor, but since they're not surgically curable, if we're too aggressive and we hurt their vision, we've not done them any favors. So debulking enough to get the mass effect away, relieve the symptoms, get a diagnosis, but not so aggressive that we harm their vision. And
so what's the risk?
Discretion's a better part of valor there.
Yeah, what's the risk? What is the risk you tell the patient and the relative, the family, when you are talking of a chiasma, suprachiasmatic lesion, when you are going for decompression? What sort of risk of vision compromise because of the operation? What do you say?
I tell them that there's a small risk that vision could be worse when
and what's your
surgery, but if we don't do the surgery, the vision's going to get worse anyway.
And what is in your series, and what's the incidence of worsening vision?
I've not studied that in my series, but I think it's probably less than 15%.
Okay, so 10% plus. So that's a good number.
Yeah.
We have to warn the family about this possibility, right? Okay, then
Right.
The other question is from Dr. Kevin. Should we prescribe temozolomide for the adjuvant after surgery?
There's no evidence that temozolomide is of any benefit to these patients.
So what's the first line of chemo you give to your patients for the chiasmatic lesions?
Standard low-grade chemotherapy for us is carboplatin and vincristine or vinblastine.
Okay. All right. If there is no other comment, thank you very much, Rick. It was a pleasure and privilege to listen to you. It's a comprehensive review of a very large experience with optic pathway glioma. Thank you very much indeed. May I now request Professor Luis Borba.
Thank
Luis.
you.
I'm here.
Yeah. Can you share your screen, please?
Yeah. Oh, sorry. Okay, the sound is okay.
By the way, before you start, I just want to inform and welcome Professor Alberto Delital. I see that he joined it. Thank you for joining. I will call you and introduce again once Professor Borba has finished his talk. Please go ahead, Luis.
Oh,
thank
you can introduce him, no problem. Okay. First of all, I want to thank Professor Misa and all the Indian Society for the opportunity to share some of our ideas about the skull-based surgery. 90% that I learned in skull-based surgery is because of this man, Professor Osama Al-Mefti. I have the pleasure to spend more than 3 years in his lab. I was the first research fellow he had. I organized the first lab in 93, from 93 to 96. When I went back to Brazil, started to do neurosurgery. There is no skull-based without lab. There is no skull-based without training. And more you do skull-based, more you learn, and more you see that is important to learn how the approach. It does not mean that you need always the skull-based approach. It means that you need to learn and know the skull-based approach. It's the most important thing that the message in the skull-based. When I talk about skull-based, come out one area. They call the petroclival area. The most confused area, because the definition of the petroclival area is very confused. Today you see in the literature tumor that's coming from the tentorium that they say that's the petroclival meningioma. Tumor that's coming from the posterior part of the petrous root, they call petroclival meningioma. But the real petroclival meningioma is the one that's related medial to the fifth nerve. Totally, when the attachment, you have attachment in the petrous, but always in the clivus. You can divide the petroclival area in 3 areas. the superior part, the middle part, and the inferior part. The superior part you can reach by the anterior petrosal approach you are talking today. The middle part you can reach sometimes by retrosigmoid approach in some variation. In some cases, you need the posterior petrosal approach that you come in the pre-sigmoid area. In the inferior part of the petroclival area, you can reach by the extreme lateral transcondylar, or sometimes a very simple approach to the lateralism. The approaches you need to do is the approach that the patient needs in each situation, not the approach that you know. But today you have a new player in this area. They call the endonasal approach. And a lot of people around the world start to advocate to use the endonasal approach to intradural lesions, especially meningiomas of the midline. But it's very interesting, if you go to the literature, and you go and see the article that they published, the people that is doing endonasal, you see, the lateral limitation is the sixth nerve. If the lateral limitation you have, Dusty, 8.8 millimeters to work. But when you see in the endoscope, you see a very large view. Looks like you have the whole sea in front of you. But in majority, is a very limited area. And this way to get the approach, to get the tumor, you have sometimes these very small grapes. But the people the tumor that we see here in Brazil, I'm sure that you see in India, is more than this. Is bunch of grapes, and sometimes it's the whole bottle of wine, the so large tumor that you have. See, endonasal approach, very limited approach, very limited lesions, very locate centrally, that you can have this the approach correctly. I never saw this petroclival meningioma. I saw some case in the craniocephaly junction, very small, but I never saw in the petroclival very small between the sixth nerve that you can reach and remove safely by endonasal approach. I think endonasal will be one more of the approach that will be developed and will disappear with for petroclival meningioma, for intradural, not for pituitary, not for chordomas. I talk about petroclival, midline, intradural meningioma. When I see today the people say, oh, you don't need to learn temporal bone. You don't need to learn petrosal approach. You don't need to learn anything. You can do everything by pteron approach. You can do everything by retrosigmoid approach. But when you go to China, you see this guy, 1,546 petroclival meningioma. It means, but in more than 50% of the case, he used the transpetrosal approach. It means you should learn the petrosal approach. If this guy has 1,546 cases and he used in more than 50 cases petrosal approach, maybe he's right. Maybe the petrosal approach is still alive. We are going back to see the Professor Kawase developed the petrosal approach, the removal of the petros apex to reach the area where is the petros apex. But today, if you understand of the anatomy, you can use the anterior petrosal approach and combine with one anterior approach. You can expose all the posterior part of the cavernosinus. You can go back and expose some area of the posterior fossa, but there are some limitations of the approach. The approach is the size or how much you can reach in the posterior fossa. The inferior limit will be the internal auditory meatus. For intradural lesion, it's very difficult to reach from this here, because this is limited to lesions located in the upper clivus, posterior part of the cavernosinus, coming from the tentorium, but the inferior limit will be the internal auditory meatus. If the tumor goes down here, not the bulge of the tumor, the attachment of the tumor. When you want to do any skull-based meningioma, the first thing you should do, try to get the first MRI. If you have one MRI when you can see the attachment of the tumor. If the attachment of the tumor is here, your approach has to be planned to attach this area, the attachment of the tumor, not the bulge of the tumor. See, the attachment of the tumor. If your attachment of the tumor is in here, you can remove by the anterior petrosal approach. But what's the trick of the petrosal approach? The trick of the anterior petrosal approach is totally liberate the trigeminal nerve, open the portum trigeminalis, it liberates totally the fifth nerve. You can mobilize the fifth nerve, lateral, medial, superior, and anterior. The CT scan in the pre-op is very important to understand the size of the petrous apex and the size that the room that you have that work in this area. Other point that is very important when you do the anterior petrosal approach, you have to understand the vein, the temporal lobe, not only the bridges vein, but also you should understand the anatomy of the tentorial sinus. Because sometimes, like in this situation here, maybe you cannot cut the tentorial or get to do a different cut of the tentorial. You have to plan your approach sometimes related to the veins or the tentorial sign. If there is a large tentorial sign, maybe you should abort and do a different approach, a different way to reach this tumor. Maybe by paternal approach in first step and retrosigmoid approach in second step. Maybe you cannot do this approach around the tentorium. To understand the anatomy, it's very important to understand the extradural anatomy. To identify the petrous apex, know where is the carotid artery, the ICA here, know where is the middle meningeal artery. But important, you need to know the anatomy. It does not mean you have to expose the whole area. You need a 3D vision. This 3D vision, you know where is the artery, you know the great superficial nerve, and you do the peeling of the middle fossa to extend the approach. The idea is to remove the petrous apex, the inferior petrosal sinus will be the limit, remove the maximum that you can, you expose the dura of the posterior fossa, you liberate totally the trigeminal nerve and mobilize the nerve lateral, medial, superior, this is what you have. But in the posterior fossa, the limit will be this, the inferior, the internal auditory meatus. When the attachment of the tumor is going down here, you cannot reach through anterior petrosal approach. You also need to understand the anatomy of the tympanic cavity, especially this area, called the tegma. You never open this. If you open this, you can have a CSF leak. You see, important to preserve, but you need to know where is the internal auditory meatus, to know where is the cochlea, to know where is the superior semicircular canal, the arcuate eminence, but you don't need to expose. Also, the trick to save the cochlea, you start to remove the petrous apex, the anterior part. You go inside and go back. One start to be hard, and in this superior, more lateral and medial here. You see, medial here to the carotid artery and posterior here. Here will be the cochlea. This bone start to be very, very hard. See, if you start to be hard, we stop drilling. The petrous apex is like a soft, like a cancellous bone. See, have to keep the dissection in the cancellous bone. But what to do? How to do the approach? When you do skull-based approach, you have to think how are you close the cavity, because these have to prepare flaps. The way you do flaps, you can do the approach. So the technique, you save the superficial artery to the flap, you identify, you see all the fascia of the temporalis muscle, you dissect the fascia of the temporalis muscle. In the end of the surgery, this fascia, you go down to cover the base of the skull. Totally the base of the skull will be covered by this part here. You can go down here and expose the zygoma, do a superiosteal dissection. You cut as posterior as you can, as anterior as you can, but subperiosteal dissection to save the frontal branch of the facial nerve. In V shape, cut like this and cut like this. Now I'm putting first the mini plates. After I put the mini plates, I cut in the middle, and I know the correct way they will come back. Never take this bone out, because the masseter muscle will be attached underneath. It's important to keep this to help in the masticatory function in the post-op. And remove, displace the temporal muscle as anterior as you can. This posterior part of the temporalis muscle you can use also as a vascularized flap to close the cavity. And do a very simple craniotomy. Very simple craniotomy. Now I'm standing a little bit more to the frontal part. Go in your base. Okay, this anterior part here, I prefer to use not the craniotomy, but the bird you can cut to go as low as you can. And do a simple craniotomy, expose the base of the temporal lobe. I'm expanding a little bit more here in the frontal lobe to get CSF leak and to relax the temporal lobe. In the anatomy, you can do this. It's the surgery in the cadaver. You see to hold the anatomy. Here is the middle meningeal artery. You cut the middle meningeal artery, start with the peeling. Peeling is peeling. You do the peeling and cut just small fibers that remain there. And do the dissection in this direction, anterior to posterior. Here's right side, okay? How to identify the great superficial petrosal nerve? You don't need to identify the nerve. You identify this band, this dural band. The nerve will be inside here. It's the way to protect the nerve and the way to protect traction to the geniculate gland. You identify all the petrous apex, see? It's different bone, see? One of the tricks that I learned, I don't use spatula. I give this stitch, you have more space, and you work parallel to it. See, you go to for the border. See, here is the superior petrosal sinus. You identify the whole petrous apex. You start drilling inside, first from inside and after it's outside. Go as deep as you can to identify the dura of the posterior fossa. Where is the ICA? It's here. I'm not looking for that, but I know where is the ICA. Identify the dura of the posterior fossa. Always I do a small hole here to take CSF leak and release the CSF leak. Now I have the dura in the posterior fossa. I have the dura in the middle fossa. What is in the middle? The tentorium. The superior petrosal sinus, the dura of the posterior fossa, the dura in the middle fossa. I open the base of the dura of the middle fossa. This place there have the whole tentorium here. If you work parallel to the base of the skull, you work in this direction here, see? But the window will give you when you open and cut the whole tentorium. It's very important to understand that the last cut is the most important cut. We need to identify the fourth nerve. Where is the fourth nerve? Before to give the fourth nerve, where is the fourth? Identify the fourth. You know where is the fourth nerve? Now you can cut back, and you put back, you put anterior, and you have the whole window here, the petroclival, the anterior petroclival area. But many tumors in this area are arising from the tentorium and come from the posterior part of the cavernous sinus. And some of them are not in the cavernous sinus. It's here, see, in the Meckel's cave. Because this you need to liberate totally the five, liberate the fifth nerve, immobilize the fifth nerve. You can remove this part of the tentorium, and the tumor that is in the posterior part of the cavernous sinus that is coming from the Meckel's cave, you can remove safely. It's different when the tumor is coming to this area of the cavernous sinus. This area of the cavernous sinus in my hand, I cannot remove safely and without deficit. This anterior part, the superior orbital fissure. But this posterior part, you see, is very wide. You see the artery here, the tentorial branch, the Bernasconi-Casinari artery for the tentorial meningioma. What's the trick to find the sixth nerve? Just displace V1 laterally, you find the sixth nerve. Here, see, is the big part, is the triangle, is the Parkinson triangle, is the largest one. You can mobilize the fourth here, the carotid artery here, the sixth here. I'm talking about meningioma that's coming from outside to inside, not the meningioma this arising in the cavernosinus. The meningioma that is arising in the cavernosinus, I just do the decompression. I don't try to remove the tumor that's here because the morbidity is very high. But the tumor is coming from the petroclival area, coming in this direction. I can just follow the tumor from outside to inside. You see here, posterior fossa, fifth nerve, you have all the area here. You can extend more anterior, find the ICA, and find the whole, you see. Can work it parallel and under the base of the skull. One very important issue when you do skull-base surgery is how to close the cavity. Today, until one of the complications that people have with the flap. When you start to do from the nose, what was the biggest complication? CSF leak. They developed a pericranial endonasal flap. Now, the level, the number of CSF leak is very low. When we start skull-base surgery, Dr. Omefti and many skull-base surgeons, we start to do very nice dissection. Look at very nice idea. When I go to the middle fossa, when I go to the base of the skull, you cut the zygoma, you take the temporalis muscle and cut the coracoid process of the mandible and elevate up. Very nice, very anatomical, very nice approach. And you put back and you work in the base of the skull. What's the problem here? How I close the cavity. Today, you know that you need flaps. You need the regional flaps to go around, and vascularized flap is the best flap. You can use Duragen, any kind of this fancy Dura replacement, but no one is as good as the vascularized flap that you have in the head. You can use the fascia of the temporalis muscle, you can use the pericranial up, and many times I use fascia lata to close and rotate the cavity that to avoid CSF leak. Let's show some cases here. Here's a large chordoma that was coming this direction. It was the posterior part of the cavernous sinus was not real in the cavernous sinus. This case was displacing. You can, from the middle fossa, left side, you do the peeling, you just coagulate a little bit the dura and peeling. Peeling is peeling, you see? You just cut the bands that remain if they see. You identify the middle meningeal artery, you cut the middle meningeal artery. In that time I was using Surgicel, now you can use glue. See, you can use a lot of glue. Start to peel in the posterior part, here's V3, start to come in this direction here. Now we come into the petrous apex. When you go to the petrous apex, see what's happened? The tumor is coming out. In the chordoma, the soft part is the easiest way to resect. You go, dissect the tumor, remove the tumor, and continue the peeling. You see the V3 here, the Garcerian ganglion here? There was no invasion of the cavernous sinus. The cavernous sinus was just displaced anteriorly and laterally. You follow it, here's the dura of the posterior fossa. You can see here, totally extradural. But sometimes the tumor go and open a hole in the dura mater. You have to follow the tumor from outside to inside. But what's the most difficult issue in chordoma surgery? Know when to stop to remove the bone. Because you can remove the soft tumor When you start to remove the bone, you see normal bone. But if you continue drilling, you find island of tumor. It's the biggest issue in chordoma surgery. Know when to stop to remove the bone. The nerve navigation help you, but sometimes the nerve navigation don't give you all the information here. Okay, you are coming from outside to inside. Here's the greater superficial nerve. Here is the ICA. We were in this situation. It's a bony tumor. I have to remove. I need to expose the artery. But when I use for the approach, you don't need to do it. In the end of the surgery, you can take the fascia of the temporalis muscle or the fascia of the C and close and rotate to close the cavity here. You do the C, maximum that you can, you expose the whole area in this direction here. And the pre and the post op, you rotate the muscle, you rotate part of the muscle, posterior part of the muscle, rotate the fascia to close totally the cavity. Some situations like this is more difficult than the one, it's totally inside the bone. What to do? Do the anatomical dissection. See, do like cadaver dissection. Remove the anatomy here, find the tumor inside the bone and try to move maximum that you can. In this situation, what you did, right side again, V3, V2, the peeling of the area, expose and remove maximum that you get in the bone, expose all the artery, the carotid artery here, the great superficial nerve will be there. In this situation, I had to come lateral also because the tumor was inside the bone. I had to go lateral and remove more as you can and do in the pre-op and post-op a big hole to remove the tumor. And ours complement with radiation therapy. Now I change a little bit the petrosal approach, the anterior petrosal approach. You know what I'm doing now? You see different here? I'm coming. I used to put lumbar drain, but I was not happy with the lumbar drain. The temporal lobe was not always coming well. And I had one idea. I follow one guy from India, from Nepal. I'm Syrian. He will talk about the cisternostomy. You see, I do this for anterior petrosal approach. I don't know if you work for the other thing, but for this, I can, in the base of the frontal lobe, go the carotid system, and take a lot of CSF, and release a lot of CSF. What's happened? The temporal lobe relax much, much better than when I was using the lumbar drain. In this situation, I never more had this kind of complication of the temporal lobe. You see, it's totally relaxed. You see the space here? Not use any spatula. This is the space that gave me releasing CSF, just it. In this situation here, cholesterol granuloma, there is no bulge in there. Great superficial petrosal nerve. 3 ways to treat cholesterol granuloma. One, you can come from the nose and drain. What's the problem? The mucosa come up and close the hole. Second way, come from the mastoid, the infralabyrinthine area, okay, and drain, put a drain. What's happened? With the end, the drain will be closed. The only one that can be, maybe, curative when you come from the middle fossa. What's the problem here? You need to do the craniotomy, come extradural, and remove all this membrane. Try to remove the maximum that you can here to release out the cavity. You need to expose medial and lateral to the ICA. See here, I'm working lateral to the ICA. The ICA is here. I'm drilling lateral to the ICA, medial to the ICA, and expose this area here and try to remove this here. While I'm pushing, looks very aggressive, you know, the ICA is here, oh my God. But I already liberate from the ICA. I know that the ICA is totally free, but you have to remove all these pieces here. What has helped me today in this approach for cholesterol granuloma? The endoscope. You can put the endoscope here, the third degree endoscope. You can see if the cavity is open. But you have to be very, very careful if not open this to the nose. If you open to the nose, if you have a small hole here, you can have CSF leak. And take the fascia, the temporalis fascia, and part of the temporalis muscle, and put down here to close. You see the pre and the post, the pre and the post. The characteristic of cholesterol granuloma, white in T1, white in T2. But the anteropetrosal approach is designed for this pathology, the trigeminal schwannoma. Do you know why? The tumor is coming from outside and from inside. I see today many people doing two approaches for this. First, middle fossa and after posterior fossa. Sometimes come the pteron approach. Is the extradural lesion coming from outside to inside. If you just follow the tumor, you do the peeling of the middle fossa, identify the Gacerian ganglion, identify V3, remove the part, the remaining of the petrous apex. Sometimes was totally destroyed by the tumor. You cannot just follow. In what the great advantage to come here to reach the tumor, the posterior fossa, the arachnoids. The arachnoid will remain to the nerves. The arachnoid will remain to the vessel. If you are coming from the posterior fossa, we are working between the nerves, have to direct the arachnoid to reach the tumor. From this part here, you keep the arachnoid to the nerve. Maybe safer for the nerve, you're coming inside, like an onion. You know, onion, you go take layer by layer, and the tumor start to come out. When you start to do this, you become more courage. You see, now I can do. For this case, what's the logical way to do here? The logical way is coming retrosig. Do a retrosigmoid approach, come from the posterior fossa, remove this because the main tumor is in the posterior fossa. I agree that the logical way is coming from here. But I had the same idea. If this extra here, the arachnoid will be back, I can protect the vessels, I can protect the perforators, I can protect the nerves. I don't need to work between the nerves. I work inside the tumor, make a big tumor, a small tumor. This way that I did. I came from the Petrosal approach, anterior Petrosal approach. I cut the middle meningeal artery. I did the peeling of the middle fossa, okay? Started the peeling, identify the petrous apex, and still have a large piece of the petrous apex. Identify V3, okay? You are coming back down, dissect the fifth nerve here. You see here, the Gacerian ganglion, take CSF leak. You see that the tumor will be more in the posterior fossa. The tumor was coming more from the root than from the ganglion. We remove the part that was in the middle fossa. Now you have V3, you have V2, have the Gacerian ganglion here. You remove the petrous apex here. This way you can widen the approach. You identify the root of the fifth nerve. You open the portum trigeminalis. Here's the superior petrosal sinus. You cut the superior petrosal sinus. Now I communicate middle fossa with the posterior fossa. Communicate extradural with the intradural. The root of the tumor will be, the root of the fifth nerve will be here. The tumor will be like this. What you can, you You can now intradurally open the dural, the base of the middle fossa, how I showed before. You see, you shrink the tumor, the bulk of the tumor. Now you see the perforators and go dissect one by one, but keeping the arachnoid to the vessels, the arachnoid to the nerve. This you can dissect this peeling like an onion. You see here, the tumor will be here, this remaining part. You can take the ball in the posterior fossa. It still remain one small piece here in the intergeminal, in the poro intergeminalis, in the Meckel scale. See the 6? You cannot see very well because the arachnoids are to the vessel. You have some small venous bleeding. You can put just a small thing of teeth. You follow, see, what is the 5? Let's see the 4th nerve? The arachnoid to the 4th nerve. I even see it. See the 6? See the basilar? Look the 5. From the posterior fossa to the middle fossa. Just following the anatomy. Just following the 5th nerve. You see here? You close the cavity here with the temporalis fascia, and the post-op has some 6 here. They'll come back. Facial nerve preserved, function preserved, and the patient is very well in the post-op. In the MRI, pre-op, post-op, pre-op, post-op, pre-op, pre-op. Just following the anatomy, just following the nerve. Another situation here is the meningioma. This patient had 4th nerve. You do remove on block here. You see, is the tentorium is here. The patient had 4th nerve in the pre-op. It does not mean you have to dissect the 4th nerve. You can take his teeth. The problem is the tumor come to this part. In meningioma, as I said, it's not cavernosinus meningioma. It's a Meckel's cave meningioma. The tumor is coming from the petroscleval area, following the 5th nerve, from the posterior fossa to the middle fossa. Completely different if the tumor arises anterior here, in the superior orbital fissure. This is completely different tumor. This tumor is coming from here to here. You can follow this direction here. Same situation is the case. See, the patient wake up with 6, 30 days post-op, recover the 6. Have another situation is very small tumor, patient with facial numbness. This lady start to take hormones, see, in the gym to be more healthy, you see, in the tumor growth, you see, a small tumor here. You can come from the posterior fossa? Yeah, of course you can come. But I want to remove not only the tumor, I want to remove the dura around. I want to remove the maximum of tentorium I can get. Not to remove the bulge of the tumor. I need to remove all this area, maximum or remove of the tumor, of the dura around the tumor is the easiest, it is safest way you can get, not the safest way, is the best way to avoid the recurrence. The tumor will be here. What is compressing the 5th nerve? You can come from here, but there is tumor in the dura. What's the easiest way to remove the tentorium? From the posterior fossa in the center? Of course you can do it. But from here, if I just follow the anatomy here, if I see this part of the petrous apex, if identifying this anatomy, I can liberate totally the 5th nerve. See, the 5th nerve. You need to know this anatomy here, but the idea is do like this. Follow this here, remove the petrous apex here, and release totally the 5 that is there. This video is published this month in the operative neurosurgery on 3D. You can see the whole surgery. What I'm doing now, meningo-orbital band. For meningioma, I prefer to do the whole peeling from V2 to the back. Okay, open the base of the frontal lobe, release CSF leak. Now I'm coming to the middle fossa, very relaxed. See, middle meningeal artery, same technique. Okay, I go faster here, you can see. Working in this direction, parallel to the base of the skull, give some stitch here. Start to bleed, you put a glue, you dissect this. It's a normal cavernosinus. You bleed a little bit more. You cannot go inside the cavernosinus. Dissecting this direction, parallel to the base of the skull, great superficial petrosal nerve. Here's trigeminal ganglion, V3. This place and start, see the carotid artery here? I know where it is, I'll be away from her. I'm coming here, drill the dura of the posterior fossa, expose the dura of the posterior fossa, the base of the middle fossa. What remains in the middle? The tentorium. Where is the tumor? I cannot see the tumor. The tumor will be in the tentorium. Now I open the dura in the posterior fossa. In 3D, it will be very nice. You can see in 3D on the operative neurosurgery, it will be very nice. You have the dimension, how deep you can go is very nice. See, you take the, now you have more CSF leak. Always looking for a cistern, always looking for CSF to release. And go to cut the tentorium, start the lateral part. Now I have the tumor in front of me. All the tumor here. Go to the posterior part of the tentorium because it's safer. Anterior part to be the fourth, the posterior part, nothing. Go posterior as you can here to get the posterior part of the tumor and the dura. Now I cut the tentorium. I cut the tumor here. You see the fourth. Where is the fourth? We saw the fourth here. See? Now you can save the fourth. Here's the fifth. And I have the whole tumor and tentorium in my hand. The anterior part, now I already identified the four. I already identified the five. And can come and release the whole mass. But still you have tumors. You still have tumor that is in this posterior part. It's the fifth nerve, the third, the fourth, and the fifth. You see here? If it's the basilar artery, but still remain this attachment here in the posterior part of the cavernosus sinus. This is the most difficult part to know when you have tumor, don't have, or just the dural tail. What I do, I remove the maximum that I can in the Parkinson triangle. Remove this part here, this place. I'm using fluorescein. See, fluorescein. I remove the fluorescein. See, you start to bleed, I stop. See, there is tumor there. I put a lot of glue. Sometimes happen this. This is the glue. It was more difficult to remove the glue that escaped than the real tumor. You see the third, the fourth, the five, posterior cerebellar, superior cerebellar, and you see the heresy. But the most important is this. Look, the temporal lobe. The temporal lobe is perfect, you see? Because you are working under the temporal lobe. You see the lady in the post-op, preservation of the function, preservation of the ocular motion. She had in the post-op, immediate post-op, see, not immediate, 2 days later, a slight facial nerve. I think because of the traction of the superior, the great superficial petrosal nerve. You never know. The intraoperative monitor didn't show me that time, but always is a question about this. Here's the last case. I want to show this. See, you can do the same. You show this anatomy here. See the basilar artery. You can expose all this area. You can do the post-op. You can preserve the function in the post-op here. See. Sometimes the venous anatomy will not help you. You try to do posterior fossa, but you cannot have. You need to understand the vein. Skull-based surgery, you need to understand not only the anatomy of the artery and the nerve, but especially the anatomy of the vein to a lot. And the only way to learn this is go to the lab. Go to the lab and train. We are doing more and more anatomical course, hands-on course to learn the anatomy. Of course, if you don't know the anatomy, you don't know how to do in surgery. If you know the anatomy, you know the tips where the structure will be fixed, then you can fix it forever. I think I'll take too long time. I invite everybody to come to Rio. So for December, we have our leader, Professor Bassan, the president of the society, the federation. I'm honored to have to call this nice hotel. We hope no corona. Just corona that you have there will be the beer corona. That's the best beer that you have in Latin America. Thank you very, very much. And sorry for the long time, Professor. Thank you.
Thank you, Luis. That was a fabulous, kind of description of the comprehensive anti-petrosal approach. You covered almost all pathologies in that area. And this is a privilege and it's a treat to see you and listen to you. It's always such a treat.
Thank you, sir.
I just start off with some questions first. What is the incidence of the trigeminal disturbance or trigeminal affection after your petrosal approach for a trigeminal schwannoma and for a petroclival meningioma?
For the approach itself or for the...
When you operate, what is the incidence of trigeminal function? Not the sixth nerve, we all know, but the third nerve.
For the petrosal approach itself, by the approach, 100%, for the approach, 100% of the patient wake up with some numbness. Just the approach, just the approach. But the great majority of them recover total the function when you have the approach by itself, I had just one case that was a meningioma that had the worst complication I've ever seen in my life. You call anesthesia dolorosa. It was terrible. It was terrible. I have more than 100 cases, the anterior petrosal. I'm putting together now the anterior petrosal approach for any kind of pathology. I had one anesthesia dolorosa. It's the worst thing. The patient has anesthesia and pain. And I don't know why this patient had, because in this patient was not the tumor related, was the approach related. See? And I don't know if it was about coagulation, I don't know. I couldn't find the reason for this. Relate function with trigeminal schwannoma is related to the size. If you have a small tumor, if the patient has in the pre-op the function preserved, in the post-op, yet you could dissect the nerve, they preserve the function. Not always totally. Not always totally. Sometimes they have some numbness that remains some piece, but will depend of the size. I had cases, a small one, and the patient had no deficit in the pre-op, and the post-op was perfect. I had cases like this last one, the big one. The patient had pain, but had no numbness. See, I could save the whole nerve. The nerve was the pain was okay. He has some numbness in the post-op, and this recovered. But the majority of them in the post-op immediate, they had this pain. Some of them recovered totally, some of them doesn't recover totally. But totally, the problem in the fifth nerve is V1. I always want to be away from the superior part. I'm always touching the fifth nerve from inferior part, not from the superior part. From the superior part is the V1, is the part that goes to the cavernous sign. There I like to go more sensitive, you see. In the 6, if we preserve the 6, it will come back. See? But sometimes it's not possible. Neurosurgery is neurosurgery. I say that petroclival meningioma, not this case is small, but the large petroclival is so difficult disease, so huge tumor, that fourth nerve maybe not a big deal. Maybe sixth nerve to remove this large tumor and save the life, maybe is as a see. Okay? Answer to you?
Yeah, absolutely. Do you ever go from the posterior fossa for petroclival meningiomas in the upper clivus, upper petroclival region, and drill the petrous from from the posterior fossa target and open up the Meckel's cave as has been described by Professor Sami?
Yes, yes. I never did. I never did. But SICK is very nice. It's very nice.
Yeah.
I don't feel comfortable. I don't feel comfortable to working with the drill between the nerves there. I don't feel comfortable. We did an anatomical study that will be published now. And when we dissect from the posterior fossa, okay, and drill the petrous apex, when you are coming from the posterior, the amount of removal of the petrous apex from the middle fossa is 2 times larger. Remove much more from the middle fossa than the posterior fossa. You can say, oh, you don't need to remove too much, but the amount of removal per petrous apex is much higher from the middle fossa. But you can do it, no problem.
Okay, let me take some questions before I give it to the panel. There is some questions for you, Luis, from Dr. Professor Mohammad Fahmi Zaid. In large chordoma, sometimes the dura would thin out and chordoma invade from extra to intradural cavity. So again, when you stop drilling the petrous bone.
When I start drilling?
When I stop drilling. There is intradural extension, sometimes the dura is thinned out.
Yeah. Yes. In the great majority, Professor, great majority is very, very thin. The important message in chordoma, chordoma is extradural lesion that comes from outside to inside. Okay? You need to remove the soft tumor, maximum that you can, or totally, the soft. Everybody can do, okay? The soft one. The difficulty on the chordoma is to know how much bone you should remove, when to stop to remove the tumor. And I said this, and one famous ENT said to me, oh, we stop to remove the bone when the tumor goes. No, it's logical. It's not this way. But if you continue drilling the bone, you find islands of tumor. Because this, after surgery of chordomas, independent that if the MRI is clean, post-op MRI, no tumor. Oh, I'm the best surgeon in the world. I remove everything. You should give radiation therapy, or proton beam, or radiosurgery, or fractionated radiation. Chordoma is a mixed treatment, surgery and radiation. When the tumor is coming from outside to inside, that the dura is thin, okay, you have to prepare to close, because this, in chordoma, before open, or in skull-based surgery, before open, always be prepared to close. Have to think, how big will be the hole in the dura? Maybe very small, maybe very large, but prepare for the very large. Big flap from here, big flap from here. Maybe you need, maybe you don't need. Okay? I don't know if I answered that.
Yeah, I'll ask the panel. Dr. Batuk, do you want to comment, question something?
Yeah. Hi, Professor Borba. That was an excellent talk. Nice demonstration of the cases. Hope you remember me. We have done a 3D presentation at the same time.
Yes, we are together.
We were expected to visit Brazil in the month of March, but unfortunately.
Yeah.
So again.
Now in December we have to go.
Yeah. So I want to ask, in all cases of petroclival meningioma, you ask for a digital subtraction angiography?
I do the MRV.
Okay.
MRV for petroclival meningioma. If I'm planning to do the approach, and I'm doing also MRV for when I use retro-C also, Because sometimes the resident do the retro-sigmoid approach and open the sinus. I use the venous anatomy. It's very important to plan any kind of approach around the temporal lobe, around the temporal bone, anteropetrosal, posterior petrosal, retrosig. Let's study the venous anatomy. I think maybe more important than arterial anatomy. Arterial anatomy, you know where the displacement of the basilar, you know where you see, but the venous anatomy, I think, is very important, very important.
Second thing you have mentioned about the post-operative prevention of the CSF leak, you put a lumbar drain, like pre-operatively you put a lumbar drain.
Yeah, I'm not putting more in pre-operative. I'm not using more lumbar drain in per-operative, in trans-op. I'm not using lumbar drain. I'm using some situation in the post-operative. But when I do a total petrosectomy, that the hole is too large, okay, that I need just not only close, I need to empty the cavity. To empty the cavity, I use the lumbar drain. But the lumbar drain is very dangerous, very dangerous. But the lumbar drain, there is a trick. I was telling Dr. Mefti, Dr. Mefti was telling, oh, I have a lot of problems with lumbar drain. What's the trick lumbar drain? Shoulder side, the bag. But what's the trick? Take the bag and fix in the patient. Your patient in India is like my patient in Brazil. They get up from the bed, they go to the bathroom. If you take like this, they do like this. It's our way. Sometimes you see the patient in the bathroom with the lumbar drain here. The people is crazy. See, what I do, I fix the bag here. See, fix, put a lot of drapes here. And this is the patient can go there and come up in the middle here and come and fix here. See, second thing, when the patient leaves the operating room, is close the lumbar drain, okay? The other day in the morning, I do a CT scan. If there is a lot of air, I don't open the drain. If there is no air, I open the drain in this higher position. See? Because this is if there is air, maybe there is a hole. I need something to go there and plug the hole. Okay?
Thank you, Professor Borba. Yeah.
Dr. Muthukumar, you want to comment?
That was a nice presentation. I have a couple of quick questions. You talked about all your patients having post-op numbness. So do you think that routinely skeletonizing the V2 and V3, the foramen around the V2 and V3, will be able to mobilize the nerve a little more and decrease the incidence of post-op numbness?
No, I mobilize totally. I'm totally free. I think the trick of the anterior petrosal approach is to open the porus trigeminalis. Open the porus trigeminalis, the fifth nerve here. Open the porus trigeminalis. You mobilize the 5. Okay. When I start, I was not doing this. And that was much worse, was longer time. Now that I'm open, the patient still have, you know. I could say nothing, but the truth is the truth. They still have, but less than I had before. I don't know, it's a coagulation. I don't coagulate too much, you know, don't like to coagulate too much. See, you see, my surgery is bloody surgery. You know?
The second question is regarding your tentorial opening. I saw both in your cadaveric dissection as well as in some of your videos. You open the tentorium from lateral to medial. So is that a specific technique to preserve the fourth nerve?
Oh, it's very interesting. I start from the superior petrosal sinus and go through here. Before the last cut, you elevate and try to find. Put down, try to find. See, if I don't find the fourth nerve, I go as posterior as I can.
Okay.
Because sometimes the fourth nerve is displaced laterally, medially, that you cannot see. See, But the trick before the last cut, okay, I had many fourth nerve deficits. I still have. See, fourth nerve is very interesting for the first picture. See, I try to preserve in every case. When I see the fourth nerve, it's like I remember the olfactory nerve. Very nice olfactory nerve, the B1 here. Very nice picture. But in the end of the surgery, the olfactory nerve was not there in the great majority of the case. The fourth nerve is like the same. But I try to preserve always. I had just one case that I cut the fourth nerve, that I didn't see it. See, I didn't see it. This patient was epidermoid cyst. Was white. I couldn't identify the difference, and I cut with the scissors. Sometimes I dissect, and the nerve begins very thin and cut. But the only thing that people is doing now, I think Professor Shaker is doing, he identified the fourth and cut the fourth nerve and keep the whole length. Because when you dissect the fourth nerve, you start to damage the fourth nerve. See, when you start to pull back, it's difficult. I'm trying now, the people saying around the world that they recovered. I was not putting back. Now I'm putting back again. Put some tube, something. I don't know if it works or not. The people say this works. I think the fourth nerve works very well with glasses. If you use Prisma glasses, the fourth nerve will work. Because you look like this, you put the glasses, will be okay. Don't need fourth nerve.
Thank you.
I'm telling the truth. No.
Thank you, Professor Borba. So very nice. We'll go on to the last talk by Professor Alberto Dell'Italia. Dell'Italia, I have already introduced him. He is the past president of Italian Neurosurgical Society. He is also the Mediterranean Society president, and he is the professor and director of neurosurgery, San Carlo di Nancy Hospital, Roma, Italy. He will be speaking on a very interesting topic, 3D, 4K video microsurgery. Are we facing a new paradigm? Professor Dell'Italia, please. Alberto.
Yes, thank you for the invitation. Basant, you have been very kind. I know that a lot of friends and colleagues are following us. Also, my friend from Egypt, Nasser El Gandour, told me that he's following this very interesting meeting. So my talk is about a new perspective for microsurgery. I think some of you had already used it. It is the exoscope. The exoscope is a camera that can substitute the microscope.
Can you share your screen, please? I don't think I'm not seeing any of your presentation. People are seeing support?
Mi aiuta?
No, sir, screen not share yet.
Please share your screen, Alberto. First, you need to share your presentation.
I try. Oh, share the screen. Okay. No, vai su questa.
Yeah.
Okay, can you see me?
Yes, we see your desktop or laptop, but not presentation. Yeah, that one. Yes.
Yes.
Yes. Yes.
Okay. Thank you to my son who is here helping me.
Yeah, we see you now. Thank you.
So this is my introduction, and thank you for the kind invitation. I have nothing to disclose and nothing to declare, but you know, in Italy sometimes we say something and this is not true. But really, I want to joke about it. So this is my new hospital. This is the San Carlo di Nancy Hospital. I worked 40 years in San Camillo, so I changed the saint. San Camillo Hospital was in this area, and San Carlo of Nancy is in this area, near to Vatican area in Rome. And this is the church inside the hospital, a very modern hospital. And I had the opportunity to test this new device, this exoscope in San Camillo Hospital a few months ago, because my friend Marco Censato, who is the president of Italian Society, suggested me. He tested and he was enthusiastic. I wanted to test in San Camillo. I had it for 15 days only, and I was really, really enthusiastic, starting to speak about a changing of paradigm. All of us are so near to microscope, so friendly with microscopes, with very deep enlargement, and we cannot know surgery without a very good microscope. So for me, when some people told me, if you try this, you will abandon the microscope, I did want to understand it. But now in this new hospital, they bought the exoscope, and I changed my ideas. And I want to share with you my changing. In Rome, there is some monuments, but one is very interesting because Lars Leksell is buried here, and is an area near to my old hospital. The area is called the pyramid area because there is an ancient pyramid, and Lars Leksell wanted to be buried here. And when Ladislaus Steiner came to Rome, always wanted to come to cemetery to see the tomb of Lars Leksell. This is my history, my short history. This is Professor Guidetti with Herbert Olive Crona here, and it's very important for me to remember my teacher. And this is my friend Guido Guglielmi. I share with him my office in university, and now we recently meet in Rome in the last Congress of Italian Society. And all of us are orientated to minimal invasive approaches. Also, if I prefer to speak about precision neurosurgery. And precision neurosurgery is the platform of precision neurosurgery is made by navigation, monitoring, high magnification, and now 4K 3D video surgery. All of these instruments are carrying us toward to more safe surgery for the patient and for the doctors, of course. And so when I tested this device in which you do not use microscope, but you are sitting in front of very large screen, 4K 3D, I changed my paradigm. I don't want to make any advertise. The company is the Olympus. I tested more than one, and I think this is the best, actually. Probably in the future there will be some very good competitors, but actually the Olympus Orbi is the best. And the paradigm is changing because you sit in front of the screen and you have not to move your head, but you have to move the camera. And the camera is always also foot switch operated. So you operate with your neck very comfortable. You have not to move your head following the microscope for some approach, for some positions, but you stay standing and just you move your camera, the camera of the Orbi. This is the setting of the OR, the layout. Is very similar to the microscope surgery. The Orbi camera and the Orbi standing is lateral or in the back of the surgeon and the instrument nurse, and this is the assistant. We have two monitors, one large 3D, and the other one is always 3D is for the nurse. The nurse sometimes prefer not to wear the 3D glasses to avoid the continuous movement and the continuous accommodation of the eye. This is the last case I operated, and is interesting because we spoke before about the Kawase approach, a very, very interesting presentation. In this case, we performed the operation in 2 times. The first by retrosigmoid approach, removing the infratentorial part, like a so-called inverted Kawase approach, what Tatajiba many times proposed, and the second approach by a subtemporal approach, and this is the post-op CT, and the young girl is completely healthy, and he came home just yesterday. So we have to redesign the layout of the OR, but if you see well, there is no particular difference. So the layout in microsurgery is this, the microscope body is in the back of the first surgeon. Here, the Orbi is in the lateral or in the back. The arm of the Orbi is long enough to be put where you like, and you change the position of your surgery. So in microsurgery, you stay attached to the micro, and your arms are positioned in your sitting chair or in the border of the craniotomy. Here you stay, you don't have the gap of the microscope. You have nothing in front of you. You just have the monitor, the 3D large monitor, and so you can use less leverage of the arms. So your movements are more precise, and your hands do not move, do not have any tremor. So the main difference between traditional, I can say, microsurgery and the 3D video surgery are this. Microsurgery, of course, is still improving, and we make nobody of us want to speak about the abandoning of microsurgery. The exoscope has the charm of innovation. With microscope, all neurosurgeons are familiar, but the exoscope has a very short learning curve, just a few hours, and you are so familiar with your movements that you will be surprised. Microsurgery is going to perfection more and more the optics, but the optics, I think that the future will build the cameras. If you see how precise are the cameras of our cell phones, and you imagine these digital cameras, how can be precise and how can enlarge, how can amplify the light, probably in the future we will have also microscope operated by cameras and not by optics. And the fourth difference is with microscope, you need to move your head within the microscope. Of course, you have to follow some approach. If you have in mind the retrosigmoid approach and the other lateral approach, you have to move your head with the microscope. And if the operation is time consuming, after the operation you need a massage. And in the exoscope, you can just see it in front of the screen. The last is the head of the light of the microscope can damage neural tissues, and the exoscope has LED light that is computer self-adjusting. More, it has compact size. A true disadvantage is a not so comfort for the assistant, because the assistant is in a slight obliquous way, and sometimes he needs to move the neck. So I don't know if I can show you a short video. Yes. Okay. And this is a retrosigmoid approach. You can see, as usual, as a microscope, usual surgery, usual microsurgery. Here we can see the nerve and the conflict, the vascular conflict. This is an aneurysm. You can see how nice is the view, and we can also use a flourishing, and we can see how the flourishing can be seen, can show the aneurysm before clipping. So yes, my presentation is finished, and I would like to have the pleasure to discuss with you. If anybody of you thinks that in the future or also now we can change our work by passing by microscope to exoscope. I think this is the future, and I think also the microscope will changes without any optical lenses, but just by cameras. Thank you for listening me.
Thank you, Alberto. Can you stop sharing your screen, please?
Come faccio adesso?
So that was fascinating as technology
Allora, tolgo
improves.
da stop share.
Yeah, thank you.
Okay.
So I had also, I just had the opportunity.
Okay, can you hear me?
Yeah, thank you. So
Basant,
yes.
can you hear me?
Yes. You can hear me? Can you
Thank you. And if you want to ask me something,
Yeah.
I will answer.
Yeah, can you hear me? Alberto, can you hear me?
Non si sente?
Hello? Support, can you hear me?
Yes, sir. Hello.
Can you hear me?
Yes, sir.
Alberto, can you hear me? Alberto, can you hear me? Can you hear me?
Now the volume is okay. Yeah.
Okay, I had the opportunity to test the Surgiscope, not of Olympus, but another company. But for only a couple of weeks, they put it in my center to check it. Obviously, you need some time to get used to it. My problem was, but I see your images was very sharp in the depth. My problem when I used for a very short period of time was, getting to the corners and fixing the camera was a little bit difficult for me. I was not getting used to it. But as I said, I had just only a couple of weeks to just evaluate it. We don't have it here, but I think it will be the future because it takes away the bulky microscope. Obviously, your movements will be more free. And it will be, I'm sure you know that Professor Yassergill has actually written about the development that this is going to be the future many years back. I don't know whether you have read it. I have read it in one of his publications. I think it is also in his textbook where he has mentioned that it will be the future will be operating and seeing through the screen as we are developing now. So that's fascinating, and it's going to move forward that way. There is no question about it. Professor Muthukumar, you have any comments?
No, I don't. I don't have any personal experience with exoscope, so I am not in a position to comment on that.
And Bartuk, you want to comment anything?
Yeah, Professor, it was an excellent demonstration with the Orbi. I have a couple of questions. The first thing is suppose you want to do the transpetrosal surgery. So how you will be able to perform with this device?
Can you hear me?
Yeah, we can hear you.
Okay. Yes, we do not use Orbi for transfemoral surgery, but we do not use a microscope for transfemoral surgery. We use only endoscope. We think that the endonasal endoscope approach is now the best for the majority of the midline lesion. We use it also for microdiscectomy for the spine and for the anterior cervical fusion. Is absolutely perfect and also demonstrative for the students and for the followers.
What about your experience with Orbi in a seating position, surgery in the seating position?
Well, we don't use a sitting position, but I think it should be helpful. We use only a park bench or the Concorde position. but I know many colleagues using the sitting and probably should be better because better than microscope, because with microscope you have to move in the direction of the lesion. With this, you can stay comfortable sitting, and you just move the tube, the camera. You saw the how you can move, and you can move the camera also with the foot switch, who has come si dice, Filippo, who has un pirolino, sorry, I speak Italian to my son to understand. Un joystick, yes, joystick, as a joystick for the lateral movements.
You also shown us the ICG. So just I want to know the camera for the ICG or a fluorescence is inside that
yes,
handpiece? Yeah.
There is inside included.
Okay.
Yes.
Any issues you have found when using it? Have you found anything which is bothering you, which needs to be better?
Pardon?
Anything you have found which is not as good as in the microscope? Anything you have found, any disadvantage of this system?
I'm really sorry to say yes, it is. I'm really sorry because my perspective in all my life, in all my professional life, was microscope forever. But I changed my ideas, and I want to tell you, actually, you can use 2 or 3 exoscope, but there is no comparison. There is no race between this and the other one. Actually, this is the only one that can substitute the microscope. Also in the lateral corners of the fields, and also in very, very short angles. Is much better because it just enter the corner, the light of the camera just enter under the corner.
Sir, is there any problem with using a 3D glasses for a long duration of time?
This is a good question. I thought yes, but they are very, very light and very comfortable. And if you are immersed in this field, of course, when you are in the surgery, you don't think about anything. You think about your field. You don't mind. You don't remember you have glasses. They are very light and comfortable.
You also shown. We also see a neuro navigation screen in your operative field. So
yes.
When you want to check, that time you need to remove the glass, or it's a 3D screen?
Well, you can remove your glasses if you need to check the screen of the navigator, or you just see on your glasses there is no a true confusion.
Thank you.
Can you use endoscope along with this?
Yes, they are compatible, like the endoscope is compatible with the microsurgery. So you can use exoscope and endoscope in the same way by you use microsurgery and endoscope.
Okay. So I think there is one question. Let me take it. Will this replace a microscope in use in the future? This is from Dr. Harshad Parekh. The question is, will this replace microscope use in future? What do you think?
I think yes. I think that actually the comparison between microscope and exoscope for me is really the exoscope is winning. Probably in the future we will have some better cameras for microscope, and probably the microscope will be never built by lenses, optical lenses, but they will work just by cameras. This is my opinion, but I think that my son Filippo will see if it will be.
Right. Thank you very much. We had, I think, a very good session. I enjoyed it. I'm sure people have enjoyed it. Thank you very much, Alberto. Thank you. Luis is still there. I think Rick has gone back to work. Thank you, Professor Muthu Kumar. Thank you, Batuk Devara. Thank you, Intas, for supporting this. Thank you very much. Have a good day and remain safe. Stay safe. Thank you very much. Appreciate everybody. Bye-bye.
Bye. Bye.
Thank you very much. Thank you. Bye-bye.
Thank you. Bye-bye to everyone.
Thank you, sir. Bye-bye.
Thank you, sir. Bye-bye, sir.
Karan, please stop sharing.
Finito, penso.
Karan? Hello?
Like,